on April 15th, 2014. Hi, it's Zoe Brooks here. On April the 15th, 2014, I want to just do a quick summary of the very fundamentals of lab quality control for you. Clinicians depend on the right results to reach the right diagnosis and treatment for their patients. The essential process they're following is I'm ordering this test to decide if the patient is sick, if the patient is well, if they're immune, if they're not immune, if they're responding to therapy, etc. If the result is below a certain point, they're going to think one thing and do one thing. If the result is, say, between X and Y, they're going to think something else, and this requires no action. If the result is above a certain point, they're going to think something differently and take different action. The patient will receive different treatment depending on where the lab reports the result. Good patient care depends on good lab quality. You've got to get the results into the right pot. If you get the results into the right category, the doctor will think the right thing, do the right thing, and the outcome will be good for the patient. The clinical risk and the clinical costs are minimized. However, if you report a bad result, a clinically misleading result, then things change dramatically. The lab result falls into a different pot. Doctors make the wrong decisions, the outcome is not good for the patient, and the clinical risks and the clinical costs increase. The daily QC that we do in labs detects two problems: differences in bias and differences in precision. If the method is performing properly with a typical normal population, you will see true positives of people who are sick/abnormal at the low end and another population of true positives that are high at the high end. If you introduce a positive bias, these people who are actually abnormal, sick/needing attention are going to appear normal and not get that attention. However, these people who are normal now appear to be abnormal. These are false positive highs, these are false negative normals. A negative bias does exactly the same thing at the opposite end. People who should be normal are considered low, and people who should be high are falsely considered normal. A very similar thing happens when the imprecision of the method increases, when the method standard deviation increases. You get overlaps of both types here. When the spread of the data change, some people who are actually normal appear to be false positively low. Those who are truly positive appear to be normal, and exactly the same thing happens at. I find you can understand almost everything you want to know about lab quality control with this one simple phrase: a number is a thing of awe. The of reminds you that each number is either based on opinion or fact, and each number tells you where you are, where you want to be, or where you expect to be. The four key numbers that you need to make these decisions are the measured mean, which is based on fact and tells you where you are on average; the measured SD, based on fact, tells you the range of where you are; the true value, the source of which is specified by the medical director based on their opinion, tells you where you want to be on average; and the TEA limit, or performance standard, again is based on the opinion of the lab director, where you want to be, what is the acceptable range of quality for your lab. You may choose biological variation, CLIA limits, clinically published limits, locally assigned limits. Those four numbers determine analytical process quality. All of them can be condensed into one single number: the margin for error. Margin for error is a term you're very familiar with. It's how much wiggle room you're allowed before bad things happen. Why do you have to worry about monitoring all these changes? Well, the simple answer is things change in a lab. They always do. Obviously, every time you change the QC sample, you're going to get different QC values. But anytime you do something to the instrument, change reagents, recalibrate, or people do something differently, you're also going to see change. If you start here with one set of controls that have just been run and everything's fine, you've validated that you have zero bias, now you're going to come in and change reagent lots. Well, your mean will shift up, but it's still well within allowable error limits, so there's no problem. Now you come in and service the instrument. There's a big change. It's dropped down about 4 SD, but there's still nothing wrong with your instrument. Now you come in again, you're going to change the calibrator, you're going to recalibrate and change reagents. Now you have a small change, but this change is significant because it takes you over the allowable error limit. When you're continuously measuring your margin for error, you know the size of the change that you need to detect. So why do you have to worry about monitoring all these changes? Well, the simple answer is things change in a lab. They always do. Obviously, every time you change the QC sample, you're going to get different QC values. But anytime you do something to the instrument, change reagents, recalibrate, or people do something differently, you're also going to see change. If you start here with one set of controls that have just been run and everything's fine, you've validated that you have zero bias, now you're going to come in and change reagent lots. Well, your mean will shift up, but it's still well within allowable error limits, so there's no problem. Now you come in and service the instrument. There's a big change. It's dropped down about 4 SD, but there's still nothing wrong with your instrument. Now you come in again, you're going to change the calibrator, you're going to recalibrate and change reagents. Now you have a small change, but this change is significant because it takes you over the allowable error limit. When you're continuously measuring your margin for error, you know the size of the change that you need to detect. Of the analytical process is driven by the 4 key numbers. There are 3 personal choices that drive the effectiveness of the QC system. That is the assigned mean value you choose to put on the chart, the assigned SD, and the QC rule you choose to use. The mean and SD on the chart are where you expect to be. You expect to have the same mean and SD unless something changes. Once you know your margin for error, there is a simple process to select the correct QC rules and a full QC strategy as recommended by EP23. There's much more to QC, there's much more to quality control than just QC rules. You can use something like this optimized QC selection grid. Once you know your margin for error or your sigma, they're very similar, you can select the right QC strategy with the right rules, the right sample frequency. If the margin for error is low, you can increase the chart review and you'll know when to take additional corrective action. If your margin for error is 0, and in my books, I would say even if it's less than 1, I would stop and see what's going on. Most labs affix or sign their SDs higher than the actual measured mean. Should those 3 decisions be based on personal choices? Remember, QC charts and rules do only one thing. They tell you that where you are now is different from where you were before. You need to decide if that change is for the better, for the worse, clinically acceptable, or clinically unacceptable. You cannot do that with only a QC chart. So coming next, let me introduce you to stats-free quality with Quality Optimizer software and the brand new risk-based quality grade.